Hello, my good friend Tobias. Today we have a short chat with Professor Tobias Welte from Hannover in Germany, who is an expert in infectious diseases, especially severe diseases like the ones we see in the ICU. And of course, we will this time again focus on COVID-19. And I'd like to ask you, Tobias, first, as you are an expert in antibiotic therapy, I'd like to ask you, aren't we giving too many antibiotics to these patients? Perhaps we are too liberal with our antibiotic therapy in COVID-19 patients. What do you think?
Thank you very much, Jean-Louis. A very good question. So the answer is yes, we give too many and too much antibiotics. And the reason is because we think it's like influenza, and it's a lot of secondary infection in influenza. This is about 50%, and we use antibiotics in influenza early in intensive care, but it's totally different in COVID-19. So this is late infection, it's related to ventilation, it's ventilator complicated pneumonia, and we have a very good biomarker, which is procalcitonin. So if procalcitonin is rising, this is a very sensitive marker for bacterial infection, and we should use it to guide antibiotic treatment.
And then would you cover very widely for multi-resistant pathogens?
Yes, it's mainly gram-negative infection.
Yeah.
And if there is multi-drug resistance, a problem in your ward, you should cover multi-drug resistant pathogens. It should be gram-negative focused.
Yeah, absolutely. Now, we are here to discuss primarily the advanced therapies in COVID-19. And I guess we don't have much to say about antiviral therapies in the ICU. It has been rather disappointing. What about the monoclonal antibodies? Would you use it in some critically ill patients with COVID?
Yeah, in a niche, I would say, and these are immunosuppressed patients, highly immunosuppressed patients. When you see that there's no viral clearance, so the viral load is not going down, then you can use monoclonal antibodies, and also in patients on the ICU. But this is the exception. In most of the patients, they do not work if patients are more severely ill. And the same is true for antivirals, including remdesivir or other new antivirals, molnupiravir from MSD, which are in clinical development programs, but only for outpatients.
Very good, thank you. Now, you're also an expert on immunoglobulins. Any room for immunoglobulins? I know you are conducting a trial there.
We started a trial, or I should say, recruitment is finished using immunoglobulins in COVID-19, and the background is COVID-19 is a pulmonary infection, and more or less it's a community-acquired pneumonia. And we both have shown in a paper published in intensive care 3 years ago that trimodulin, so a broad-spectrum immunoglobulin, which includes a high IgM immunoglobulin proportion, reduces mortality in severe community-acquired pneumonia. And more or less, it's the same in COVID. So the phase 2 study recruitment is finished. I wait for the data analysis, and I hope we will see the data in August when ISAKIM starts.
Can you remind us the rationale in COVID-19?
The rationale is to balance the immune response. I think that's the main mode of action. However, these IgM immunoglobulins have a property to bind pathogenicity factors, not only from bacteria, but also from viruses. This has not been examined in cell culture experiments, but in my mind, it's possible. So we will see the phase 2 results, and if this is positive, we will move forward to a phase 3 trial.
Very good. Yeah, I'm sure you will agree with me that we need better therapies. We have spent too much time on hydroxychloroquine and and other stuff which was not likely to be effective. We could have really developed other agents. Well, what about, for instance, antibodies to GM-CSF? That sounds relatively promising, isn't it?
Yeah, that's a very interesting new target. GM-CSF normally is a repair chemokine and a repair growth factor. And in immunocompetent patients and mainly in young patients, GM-CSF promotes repair. However, what we have seen is in older patients and together with immunosenescence, it does not work in the same way. So the pathways seem to be blocked or no more active. And then GM-CSF increases the number of granulocytes and macrophages in the lung. And this is deleterious. In a phase 2 study, the so-called OSCAR trial, it has been shown that in the elderly above 70 years of age, and this is the group with the highest mortality had been reduced by more than 30%. And we started the phase 3 trial 4 weeks ago, and recruitment is still good. So I expect the phase 3 data in between the next 4 to 6 months. But a very promising approach.
Yeah, very good. What would be in your mind the other promising approaches? Anything that we are not well aware of?
Well, one I look carefully to is complement 5A antibodies.
Yeah.
So there is a phase 2 study running in intensive care patients. And from a basic research point of view, this may work because complement activation is one of the major drivers of the inflammatory process. But one of the major obstacles with studies in COVID-19 is about 20% are not pro-inflammatory. So they are in a more or less non-inflammatory stage of the disease, and including these patients into anti-inflammatory approaches may not be beneficial. So we need studies which are stratified by inflammatory markers.
So I think that's an important message. We may not find medications which are beneficial to all patients with COVID-19. We need to guide these therapies and try to personalize our interventions, right? Agreed?
Well, it's the same, and we both work in sepsis now for more than 30, more than 40 years, and more or less it's the same. So there are different patient groups, and mainly different patient groups in terms of the inflammatory status. And what we are still lacking is a easy to handle, fast track biomarker to guide our intervention. And this is something, and we should use COVID-19 for this, to look whether new biomarkers, combined biomarkers are detectable, which we can use in the future also outside COVID disease for other indications.
Absolutely. My good friend, it was very useful, very interesting. We thank you very, very much, and we are looking forward to seeing the results of these most recent studies. Take care. Bye-bye.
Thank you, and have a nice day.